Thank you for your time. My talk is regarding a project that I did a short while ago in pre-op, which was looking at functional capacity assessment in pre-op patients, so specifically colorectal patients over the age of 70, and comparing the shuttle walk test to CPET. And this was a presentation that I presented to a wider audience, so at the risk of teaching ducks to suck eggs, I'll skim over the bit on functional capacity assessment. But obviously, it's an important part of pre-op assessment. It helps to establish or predict a patient's likely physiological reserve and determine their ability to cope with demands of major surgery. And we know that, generally speaking, patients with better functional capacity are less likely to have complications, probably have a shorter length of stay and a lower rate of perioperative mortality. And when it comes to assessing patients preoperatively, it's a really important part of risk stratification. It allows for shared decision-making and perioperative planning. There are subjective and objective methods of functional capacity assessment, and CPET is regarded as the gold standard objective method. It's more expensive, requires trained personnel and specialised equipment. And alternative objective assessments of functional capacity would include the shuttle walk test. So this is a picture of a bleep test because I couldn't find anyone actually doing the shuttle walk, but essentially the principle is the same. Your patient's walking backwards and forwards between two cones. The speed at which they have to walk increases every minute in time to an audio signal, and then the test is stopped when the patient can't get to the next cone before the signal goes off. And we calculate an incremental shuttle walk distance from that. And comparatively, it's simple, inexpensive, and readily accessible. I've put the CPET thresholds that we use for risk stratification or risk assessment on here. I'm sorry for those who are more familiar with CPET, but for those who aren't, to give you an overview, there are multiple thresholds that we get from a CPET test, but the three that have been most broadly studied specifically for perioperative risk prediction are peak VO2, so the peak rate of oxygen uptake, and the value of less than 15 mils per kilo per minute is deemed to predict higher risk. Anaerobic threshold, or the VO2 at which oxygen demand exceeds supply and the patient starts to metabolize anaerobically, of less than 11, and the ventilatory equivalent for CO2. So that's the ratio of minute ventilation, or VE, to carbon dioxide production at anaerobic threshold. Overall, that's a measure of gas exchange efficiency, and a value of greater than 40 at anaerobic threshold has been associated with poorer long-term outcomes. So essentially, anyone who achieves less than 15 on a peak VO2, less than 11 on an anaerobic threshold, and greater than 40 on a VE over VCO2 at anaerobic threshold would be deemed to be at higher risk of perioperative complications. And probably the effect is cumulative in that the more sub-threshold CPET variables they are, it probably has a higher predictive value for identifying high risk patients. Sorry, that's a very quick whiz through. So there have been multiple studies looking at the comparison between shuttle walk tests and CPET that have looked at various different thresholds in various different surgical populations. Less than 250 meters in patients undergoing lung cancer resection and major colorectal surgery was associated with an increased risk of major complications and mortality. More than 350 meters in esophageal or gastric resection was associated with a better median survival than patients who got less than that. And more than 360 meters in elective intra-abdominal surgery was shown to be predictive of achieving what would be described as acceptable or normal risk CPET parameters. So all of the patients in that particular study who got more than 360 on their shuttle walk went on to have more than 15, peak VO2 rather of more than 15, and an anaerobic threshold of more than 11 when they subsequently had their CPET. Similarly, 400 meters for patients undergoing lung resection was also shown to be predictive of a peak VO2 of more than 15. So essentially, patients who get less than 250 meters, I think we can conclude that they're likely to require formal testing to quantify their functional capacity. But there is a possibility that for patients who get more than 360 or more than 400 meters, there's a possibility that they're very likely to have normal or acceptable risk CPET parameters when they undergo testing. probably at a lower risk of post-operative complications as a result of that. And for that reason, in the perioperative setting, might not necessarily require formal CPET testing. So my aim was to try and assess whether the shuttle walk test could be used as a screening test to try and identify patients who might not necessarily require pre-op CPET, in the hope of leading to a potential cost saving, reducing the waiting times for patients who do need CPET, not just in the perioperative setting, but generally it's used for multiple other reasons in other settings as well. And at a time when the patients are often going through lots of different hospital appointments, to reduce the number and hopefully improve their experience as a result of that. Currently, in colorectal patients over the age of 70, we were doing CPET in all of them. We were also doing the shuttle walk test routinely in prehab, but not really using that data in our pre-op pathway. So I did a retrospective audit of all of those patients in that group who had undergone both the shuttle walk as part of prehab and CPET between April 22 and December 23, and used previously published thresholds. So I wanted to assess whether those thresholds of 250 meters or 360 meters that have been previously published could identify patients with acceptable CPET performance in this population, and I used positive predictive values to try and demonstrate that. Overall, there's a relatively even split between men and women, a mean age of 77 and a mean shuttle walk distance of 250 meters. The mean CPET variables were, as you can see, they're all within what would be regarded as an acceptable or a normal risk profile for proceeding with surgery perioperatively. So mean peak VO2 was 17, mean AT was 12.8, and mean VE/VCO2 was 33.6. There were 111 patients who completed both tests with a mean interval between the tests of 6.8 days. 21 patients achieved a distance of more than 360 and 55 achieved a distance of more than 250. Quite a bit of information on this slide, but I'll just narrow down really on the 360 meter data. So of the 21 patients who achieved a distance of more than 360 meters, 19 of them had a peak VO2 of more than 15, giving a positive predictive value of 0.91. You'll notice that the negative predictive value is significantly worse than that, and I'll talk more about why that might be towards the end. A similar pattern for a 250 meter threshold, but the positive predictive value, as you would imagine, not quite as good. For an anaerobic threshold of more than 11, there was a positive predictive value of 0.95. So 20 of the 21 patients who achieved more than 360 meters on their shuttle walk had an anaerobic threshold of more than 11. And the results were the same for predicting VE/VCO2 less than 40. From that, I concluded that a threshold of 360 meters demonstrates a reasonable ability to identify patients who are likely to have CPET parameters that would be deemed acceptable or satisfactory to proceed with surgery. The positive predictive values for that threshold predicting all of the parameters that I've mentioned before were in excess of 0.9. And I feel that the shuttle walk test can be used, or it's reasonable to use it as a screening tool to identify patients in this cohort who might not necessarily need further CPET testing. And for this cohort of patients, that would lead to a potentially 19% reduction in the number of tests, a significant cost saving, and hopefully improve patient experience. As a result of that, there's been a change to our prehab pathway, or our pre-op pathway. So this is the new flow chart that they follow in prehab now, which this should say age more than 70. So if the patient's over 70 and awaiting colorectal surgery, they go to prehab. They achieve more than 360 meters on their shuttle walk test. If they've already got a CPET ordered, that can be cancelled. It can be used for another patient. If they haven't already got a CPET ordered or booked, they don't need that appointment. That can be used for somebody else, save a little bit of money there, hopefully, and potentially increase or improve the use of the waiting list for those patients who do require it, either perioperatively or otherwise. As I mentioned, the negative predictive value of the thresholds is not very good. So poor shuttle walk tested performance doesn't necessarily mean they're going to get a high risk CPET. There's probably a number of reasons for that, but I would suspect musculoskeletal reasons. So patients who are simply not able to complete the shuttle walk for whatever reasons, because they can't walk or have difficulty with that, but are much more comfortable sitting on a bike and demonstrate reasonable cardiovascular reserve. And overall, there are a significant number of patients with satisfactory CPET performance in this population. And the high prevalence of satisfactory CPET might explain the high positive predictive values of the test. Obviously, it's single centre, a single cohort, but I would say that's comparable to the other studies that are available looking at the same thing. And for this, I didn't compare outcomes between groups, but that's something we could look at going forward. And the plan is to try and assess this, to assess the new pathway, see how many patients it affects, look at how much money that's saving, hopefully, but also to look at the outcomes of those patients and review things going forward. Thanks very much for your time. So please, if you've got any questions, again, happy to take them.